Hi. So last time we got a little bit of our way through this until I got real thirsty and couldn't answer anymore. So today I've got my little drink with me and we're ready to rock on. So we've done an introduction to the session that is assessing the obstetric patient. We have gone over what we might assess within this assessment. We did the approach to the patient, red flags, vital signs, history taking. We talked about miscarriage and we talked about ectopic pregnancy. And I believe that's where we left it. So we're going to continue on in this. So here we are, we're preeclampsia and we'll work our way down the whole way through to sepsis and maternal deaths. Okay, so preeclampsia. I have a video here that tells you what preeclampsia is. It's not a very long video, but for those of you who prefer something more visual, this will help. So preeclampsia is basically it's high blood pressure in pregnancy, but it doesn't just present with high blood pressure. That's the cause of it. Preeclampsia will present as high blood pressure, protein in the urine, fluid retention, and then you'll get a kind of neurological impact to it as well. Because as you can imagine, with the high blood pressure, your intracranial pressure might be changing too. So therefore, you might get vision problems, headache. You might have a bit of other neurological complaints as well. So there might be a little bit of photophobia. There might be a little bit of behavioral changes. There might be a reduction in GCS. So for you guys that are out there assessing this, it's going to be difficult to say, is this preeclampsia or is this meningitis or encephalitis or a different brain infection? So the main difference, obviously, is that it's in pregnancy and the high blood pressure. So glance back at the maternal notes, see if there has been any record in the clinical assessments of blood pressure taken, see if the patient is aware that the blood pressure might be high. Definitely take a blood pressure on both arms and take it more than once on both arms. You don't want a white coat syndrome. You don't want a Hawthorne effect, anything interrupting your obs. So set your BP cuff or do it manually to go off like every 5 minutes or every 10 minutes during the assessment. So you can decide whether this is hypertension or not. When we mean hypertension, that usually means on the systolic, but do check the diastolic as well. So hypertension, basically, with the systolic, it's basically anything over 140. With the diastolic, it's more like over 110. But keep a note of them. So with preeclampsia, this usually occurs in the latter stages of the pregnancy. So it's not often that you'd see that at the start. This is because, you know, the changes within the body aren't that acute in the first trimester or indeed part of the second trimester. But when that baby starts to get huge and squishes everything, you can imagine, just like you're doing with your tension pneumothorax. Remember the medium-sternum shift? So if everything's pushing onto the heart, the blood pressure has to increase a little bit. So increased blood pressure, going to give you all the signs and symptoms of high blood pressure and, the neurological effects with the high blood pressure. So what you need to do is to think this is preeclampsia until you know otherwise. So if the blood pressure is low, it's not going to be preeclampsia. If the blood pressure is high, it might be. So think about it. Is there anything we can do about that? No, there's not really anything we can do about it, because you don't want to be given something like a vasodilator or anything like that to try and reduce the blood pressure. That's not what we do. This will be treated in hospital with a course of medication. It will not be treated by us. Our job is to recognize it and to get the patient into hospital. So sometimes you'll get the pain with this just below the ribs, so it can be quite high up as everything's pushing, the headache, the high blood pressure. Preeclampsia on its own isn't dangerous, it's quite common, but it might progress. If it progresses with any type of seizure, it becomes eclampsia, and we're going to come on to that in a moment. So with eclampsia, all of the signs and symptoms of preeclampsia, which hopefully you should know about now. You can pause and say them back to yourself, hopefully. But some seizures. So hopefully you guys know about seizures now. Since you did the Resus Room podcast about seizures, there can be a lot of different types. So if the patient's got epilepsy, this might be eclampsia, it might not be eclampsia. You have to think of it as eclampsia and think, right, this could be life-threatening, especially if the blood pressure is high, especially if they've got a headache. I know it's getting boring, but we really need to think about these things, because you come along and you're assessing somebody who's pregnant and they've got a high blood pressure. Quite a lot of people won't remember about eclampsia. If they've had a fit, people then tend to go, oh, hold on a minute, there was something about fitting, seizures, and high blood pressure, something in the lecture notes, can't quite remember what. I want you to have it in the tip of your head. So tip of your tongue, not your head. Right. The diagnostic side of things is going to be done in hospital. They need to have bloods taken in order to diagnose eclampsia and then have further medication from that. So what it's known as, and you'll need to know this because I know you don't do bloods, but you look at maternal notes and patients will talk to you and you don't want to be foolish. So the HELLP, HELP, is basically what happens in regards to eclampsia. So hemolysis is that is basically the rupture of the red blood cells and the release of their content into the fluid all around. So this can either happen intravascular or extravascular. And what that means is if it's intravascular, the contents of the red blood cells will actually be released into the blood vessels. So that can be quite bad. You can get some poisoning with it. If it's extravascular, it will be outside of the blood vessels. So that means it's going to be actually in the liver and in the spleen. And that's in the macrophages. Remember those parts that are supposed to actually kill bacteria. So the red blood cells there have actually ruptured and they're within the cells that fight bacteria. So you can imagine this is not going to end up well for the mother. So they'll take the blood sample and they'll check the liver count, because like I said, if it's extravascular, it will be potentially in the liver or spleen. And they'll also check for platelet count, just to make sure that the blood is the usual consistency and the level of cells that it should be. For us, we'll look at the signs and symptoms. So not just eclampsia, but we're looking at HELP syndrome as well. So with HELP syndrome, we're looking for this paleness, this dizziness, this confusion. We're thinking about what would actually happen to a person if their blood cells were all messed up. You know, how would they be acting? And that's how I want you to think about it. So I will come back to that question at the bottom there about anti-seizure medication, but I just want to show you this as well. So the symptoms, remember this is going to be a combination for you of the eclamptic symptoms as well as HELP in particular. So headaches, nausea, vomiting, that tends to get worse, especially the headaches. Can be upper right abdominal pain. Now, why would it be upper right abdominal pain? Well, we know that it's going to be, a lot of the pain is going to be concerned with the liver. And we know that's in the upper right quadrant, just below the ribs, just under the ribs. You'll have a little bit of fatigue, you know, like anemia. They will be pale, like anemia as well. And also some of the symptoms of preeclampsia, which we've gone over there, the headaches, nausea, vomiting, might be behavioral changes, and might be high blood pressure. So look for all of them together. You can have a look and say, I think this looks like HELP syndrome. I'd like to bring you into hospital for blood tests. That will be done in hospital. We can't do that, but like I say, we can diagnose it. So my question before was, can this be treated with anti-seizure medication? I mean, if we were in a class now, we'd have a little discussion about it. If Marlon was here, we'd have a debate. We'd be split into groups and we would be looking at yes or no. So the answer from me is, if a person is actively seizing, I would have a look in my GeroCalc. I would look up diazepam. and check that it's not contraindicated for a patient who's pregnant. Then just check your usual diazepam for fits. We're not going to treat it with anything else pre-hospitally. However, in hospital, they will do other things. So the blood pressure, the antihypertension medication, they might do lifestyle changes as well. It's very, very rare that they would try and do a release of pressure like bore or anything like that. That would be very rare, or shunt. Okay, so make yourselves aware of HELLP syndrome. The next topic is the antepartum hemorrhage. So bleeding in pregnancy is a massive thing. So we've already been over the miscarriage. So that's bleeding that occurs before this period, like in the first half of the pregnancy. Now we're talking about antepartum hemorrhage. So baby's still in utero, but it's after about 22 weeks of gestation. So any bleeding that's coming from that, you're thinking, right, this isn't necessarily a miscarriage now. This is antepartum hemorrhage. So there are two different types of antepartum hemorrhage. I've put in here 2 videos for you to make them a little bit easier, because for some people it's hard to imagine the placenta, the cervix, where it actually sits. Sometimes it's hard to imagine. You have to really get down to the nitty-gritty. What is a placenta? Where does it lie? How does the baby come out through that? All those kinds of questions. I want you looking at them. I want you researching them. So these 2 videos that I've popped in here should hopefully help you with that. But they're both very different. They do concern the placenta and they do concern bleeding, but one's a lot more dangerous than the other. So placenta previa, that is when the placenta is overlapping and implants in the cervix. That can also be known as a low-lying placenta. So if your patient says to you in their history, or it's in their notes, that I've got a low-lying placenta, you got to think to yourself, they're going to be at risk of bleeding. They're going to be at risk of hemorrhage, a placenta previa. They might not know that terminology, but layperson's term is low-lying placenta. So with this, because of the way the placenta is blocking the cervix, the baby has problems emerging. So quite often you might have to have a C-section, but most of the time it's going to resolve itself. Most of the time. Now, you're not going to know that if you're there on like 26 weeks or whatever. So you've got to be thinking about, what can I do for this patient? Any patient that's bleeding, they need to be checked out. So you can't leave them at home. So in placenta previa, you will have blood showing. That's always present. The blood is bright red. What do you know about bright red blood? It means it's fresh. All right, it means it's not an old injury or anything like that. They can present with nothing more than this bleeding. So you would question them as usual, what's the bleeding like? What's the quantity of the bleeding? Is there any clots in it? What color is it? What consistency is it? How many pads have you gone through? Remember all of that? Then you're asking them about other symptoms. Is there any pain with it? Is there any infection with it? So bleeding without pain, we're thinking that might be a placenta previa if it's within this time frame. So the patient might not, they'll be like, no, my baby's fine. I can feel it kicking away. Yeah, it's fine in there. No, don't feel any pain at all. Just a little bit bleeding. Don't have to go to hospital, do I? It's normal to bleed during pregnancy, isn't it? Well, yeah, it is. It can be normal to bleed during pregnancy. But we need to figure out what else is going on here. So if somebody's having an internal bleed and it's coming externally, you are going to see signs of blood loss. So you're looking at hypovolemia. That's not always a low blood pressure. That can be some things such as an elevated rest rate, or more likely tachycardia with a weak thready pulse. It might be a little bit irregular as well. So that's what I mean when I say check for signs of shock. So check what the blood pressure is doing. Remember, we talked about the difference between the systolic and the diastolic, whether that's narrowing or whether the gap is increasing. That will give you a different pulse pressure as well. So placenta previa, worrying, but normally doesn't end up being anything sinister, normally sorts itself out. Presents as bright red blood and painless. Check for signs of shock. Now, placenta abrupta, or abruption, on the other hand, is when the placenta actually becomes separated from the uterine wall. So as you know, it's stuck to it. If that comes away, there's going to be a lot of bleeding in there. Though that doesn't always come down the channels and be exposed bleeding. That can be concealed. So with a concealed bleed and a pregnancy, you might not even be able to do the palpation to find a concealed bleed in there because everything's so large and expanded anyway with the baby. So how on earth are you going to find a concealed bleed? Well, if there is any bleeding, it'll be more likely it'll be dark colour or a mixture of dark and light colour. It won't be this bright red constant like the placenta previa. If it's concealed, then you might not obviously have any blood at all. What you would find is that the patient presents with a constant pain. All right. Now that might sound like labour to you. That might sound like contractions that are coming constantly. I'm in constant pain. You could think that there's nothing to prove that it is placenta abrupta, but you just have to think about it. Because if the patient's bleeding in there, there's a good chance that that patient's going to bleed out. There's a good chance that they'll go into hypovolemic shock. There's a good chance that they won't have enough oxygenated blood. And there's a good chance that that baby inside there will die. So you have to take this seriously. Sometimes you will get the symptoms of preeclampsia. So sometimes you might get the headache, and you might get the blood pressure changes, but that's not always. So it's very hard to detect placenta abruption, but if you're in any way suspicious about it, get them into hospital. Well, like I said earlier, any bleeding, get them into hospital, but with placenta abruption, you've got more chance of a fetal death, stillborn, for example, and maternal compromise as well. So serious illness to the mother as well. Now, my favourite, let me take a wee drink. So yeah, PE, pulmonary embolism. Always got to think about that when someone's either pregnant or just given birth. So it can be the whole way through the pregnancy, or it can be like up to 12 weeks after the pregnancy. So think about the reasons why, and then you won't forget about PE. So you don't necessarily, in this case, you're not necessarily thinking about long-haul flights. You're not necessarily thinking about DVTs, immobility, the same as you were in the respiratory system. Yes, of course, there's still going to be risk factors, but when it comes to a person who's pregnant or who has recently given birth, there are other risk factors to add on top of that. So just on the bottom there, I've put the signs and symptoms. But just above that, I've written why are patients 5 times more likely to experience a blood clot than those not pregnant? Well, it's to do with the consistency of the blood. It's to do with the increased clotting system, less blood flow to their legs. They are walking around and moving around less. And then, of course, after birth, if they've had any type of C-section, or even if they have stitches, that's still a consideration for PE. So up to 12 weeks afterwards, or any time during the pregnancy. And we know the signs and symptoms of PE. So it can start off with DVT, swelling of one limb, pain, red, hot. It can start with the respiratory symptoms. We all know what that is. So you might have an increased need to breathe. So the respirate would be up, their SATs might be down. They might have blood in their sputum with PE. You might have chest pain. They might not have chest pain. They can, you can have a PE without chest pain. If you do have chest pain, it can be central. It doesn't tend to radiate into the left arm, like MI pain would, but it's worth considering if there's any chest pain there. If you do an ECG, you might see the PE pattern, which is S1, Q3, T3. That means deep S wave in lead 1. It means a prolonged Q in lead 3 and it means a flip T in lead 3. But most of the time, you will detect a PE from somebody having tachycardia. That can be irregular, but it will be fast, usually in a PE. So they might be short of breath with tachycardia. Think about PE. As you know, it can make people drop down dead. And this is something that we can detect and prevent. So get this patient into hospital for surgery. As we had antepartum hemorrhage, now is postpartum hemorrhage. So at this stage now, we've moved on to birth. This is a post-birth situation. So usually during labour, there is blood loss. Anyone that's been to a delivery will notice that it is blood loss. But the question is, how much blood loss? Is it significant? So I've written here, what is significant? 500 millilitres. But as we said at some stage during the course, I can't remember when, how the hell are you going to know what 500 millilitres is? You know, that's half a litre of Coke spilt. That could be quite vast. Pour that out on the kitchen floor. It could cover the whole of the kitchen floor. That's a lot. But if that's concealed in pads or in the bedclothes or whatever after the patient has given birth, you might underestimate it. So if it is all scrumpled up in towels or whatever and pushed in the corner, have a look. Try and estimate, if you can, how much blood loss. So lots of things can cause the blood loss in pregnancy, in birth, I should say. So the tone, so we're talking here about placenta and uterus. We've just talked about placental bleeding in the run-up to the birth, but obviously after birth as well, that can still carry on bleeding, especially like if the placenta was in the way, that might be trying to push the placenta down into the cervix, and that might cause some additional bleeding. Any type of trauma, obviously, lacerations, uterus rupturing or turning in on itself, hematomas, like little blood clot bruises in the pelvic area, like they might remain there after birth, causing PEs. Obviously, cesarean section is trauma, and any type of surgery could make the patient at higher risk for bleeding, obviously. So tissue can be retained. So that can mean that part of the placenta doesn't come out with the fetus or with the afterbirth. And there's nothing that we can detect about that if the patient has just given birth. You examine the placenta, you bring the placenta in, but you and I don't really know what a full placenta looks like. It's not like it's going to have a chunk out of it and you go, oh, look, that placenta's incomplete. It doesn't always present like that. So when you're bringing the patient into hospital, you'll have to bring the placenta in as well. Pop it in a little vomit bowl or in some type of bowl. You know, the patient might have a bowl to bring it in as well. Bring that into the hospital too. What was I going to say? Yes, so retained placenta might not be visible, might not be presented to you while you're there at the birth. This might come a day or so afterwards, and that would come with some bleeding as well. So if you're called to a patient who's given birth a couple of days ago and they're bleeding, then we're thinking about postpartum hemorrhage. This can be massive. I've been to one that literally there was just blood running down the ambulance. It was horrific. I don't know the outcome of that, but this woman was in serious trouble. She had lost so much, and that was, I think, about 3 days post-birth. So just be wary if you are called afterwards, and don't think it's just woman panicking or anything like that. Take bleeding seriously after such a massive trauma as childbirth. Okay, we're looking at the consistency of the blood as well. So anticoagulations and clotting disorder, making sure that the blood's not too thin. So obviously, if you're on anticoagulants or if your blood is thin, you're at higher risk of bleeding. Goes without saying, really. All right, again, I haven't written it down here, but of course you're going to check the blood pressure. Of course you're going to check for signs of shock. Of course, you're going to investigate what kind of bleeding there was, the consistency, etc. Again, another post-birth call that you might have to go to. So you might be figuring somebody's got a change in personality, or somebody is acting, behaving strangely, or they might actually call you and say, maybe I'm suffering from postnatal depression. So here's some facts for you. A third of women with postnatal depression start getting their symptoms during pregnancy, and that continues post-birth. So that's something to look out for. Again, you might see it in the maternal notes that the patient's suffering for depression or treated for depression, or they might disclose that to you themselves. But quite often it starts within like 1 or 2 months after the birth, when everyone's like, oh, it should be the happiest time of your life. But it's not. Obviously, it's not about being sad. It's about like the chemical imbalance that happens with depression. So the signs and symptoms are basically the same as the signs and symptoms for depression. So the patient is feeling low and tearful, sad. They might come up with some thoughts that just aren't their normal way of behaving, way of thinking. They might say things out of the ordinary. They might display things such as not getting dressed, not bonding with the baby, not taking care of personal hygiene. It's not like you're always going to go to these patients and they'll say, I'm really depressed. It might be partners or birth fathers or anyone calling to say, I'm worried about her. So take it seriously. If she's not behaving normally, something like not changing your clothes for a week could be a sign of postnatal depression. And I'm sure some of you know how far this can go. There are some really harrowing accounts of patients with postnatal depression. I didn't go to this call, but I can remember one of my colleagues was really shaken up because the mother had postnatal depression. The baby wouldn't stop crying. She put the baby in the oven and turned the oven on. Thankfully, somebody had alerted the emergency services, and the baby was okay in the end. But these are the kind of things, when you're not thinking straight, that can go completely wrong and can really end up with a horror story. So if you're worried about postnatal depression, don't ignore it. Don't ignore that niggly little voice that's saying, hormones are all over the place. I'm sure she'll be all right. She's got someone at home with her. Let's take her for professional help. Let's take her for a professional assessment. Don't just assume that should be all right. So yeah, look how frequent it is. You're talking about 10 to 15% of women who are going to get postnatal depression. Now, it may not be obviously to the scale that I've just described about baby in the oven, but it can still be dangerous. You have to think about how mental health develops, how it's not just a depression. It can go into psychosis. It can go into more long-term mental health conditions. It can have an effect on the baby, the siblings, anyone else in the house, and ultimately it could lead to suicide or something happening to the baby as well. So if you do have somebody who is suffering from either mental health breakdown or postnatal depression, that's your patient, but you also got to think about the baby. So unfortunately, you do have to consider safeguarding. This person, the mother, the birth mother or birth parent, is in a state where they're not thinking right. They in any other circumstance wouldn't dream of hurting their baby, but you have to protect that baby as well. So you've got two patients. Think about your welfare. Think about your safeguarding. Do you need to bring two patients to hospital because you're worried about that baby? Again, there are some mental health and pregnancy stories here and a little bit more about postnatal depression. So there's loads of resources in this PowerPoint. I do want you to read them all. I really, really do. Okay, lastly, we are going to think about maternal sepsis. So as you know by now, sepsis is in everything. We had our neonate sepsis. We have pediatric septicemia. We have it in all of the systems that we study. Anything that could get infected, you got to think about sepsis. So why are pregnant women and women that give birth more at risk of sepsis? Why are they more at risk of infection even? So miscarriages, especially those that aren't necessarily carried out in hospitals, and unfortunately that's still the case. You know, whether it's cultural, religion, or money, or shame, or whatever, some people do not have terminations in designated areas. So there are still backstreet terminations. And I know terminations aren't the same as miscarriages, but I just want you to think about the non-sterile environment that could be high risk for causing an infection that might lead on to sepsis. Of course, cesarean sections, any surgery is a risk of infection. Prolonged time from rupture of the membranes to birth. Now, how long should that be? Well, how long's a piece of string, you know? From the time that the patient's waters break until the time that she's given birth, it can be, you know, something like half an hour. It can be 48 hours. So you need to find out if the patient has got any previous births, how long that was, etc. But those more prolonged times, that's more risk of infection. Infection post-vaginal delivery. Okay, so you're exposed, basically. You're going to be exposed to a lot more types of infection. Now, I don't know if you know, but when women are giving birth, quite often they give birth to a little poo as well. So it's that pressure, obviously, with the contractions, with the pushing. Quite often you'll have a stool pop out with the baby. Nice, little baby poo. But anyway, you can imagine with that going on and with open wounds in the area that it's quite possible to get infections from the fecal matter. Same with baby meconium and things like that as well. So it's possible to get infections that way. Mastitis, which is breast infection from breastfeeding, anything with an open wound, anything that is like a pore, an opening from the inside to the outside, is going to be at risk of getting infection in. And any other infection, so your respiratory infections, your urinary tract infections, your liver infections, kidney infections, gallbladder infection, all of those, brain infections, all of those obviously are going to have a risk of sepsis. Just because the patient's given birth or is about to give birth, that doesn't mean that they are exempt from your usual infections. So it's either sepsis or maternal sepsis. As you know, sepsis is a step-by-step occurrence of the infection. So whether it gets into the systemic response or whether it stays in the blood system, whether the blood system gets poisoned and then it goes on to organ failure, or at the very end, the refractory hypotension, septic shock. So you guys should already know this because you've done a lot of sepsis, probably in Richard's course, but I'm sure you would have come across it. And I know this reference here is older than like 99% of you guys. So yeah, it's old, but it's still relevant. I'm sure you can find something more up to date if you wanted to talk about sepsis. Again, here's a World Health Organization report on sepsis. Please go into that. I find sepsis to be something that people think that they know a lot about, but then, you know, that you get caught out. You get caught out by the organ failure, or you get caught out by the non-pyrexic presentation. So you always need to keep sepsis in the back of your mind. As you know, your ambulance trusts have sepsis screening tools. Use them. So some trusts say, we don't need a screening tool anymore, it's just the news score. Fine. If you're using the news score, that's still you looking out for sepsis because it's the same kind of indicators there in terms of the vital signs. So high news score, you're going to have a high index of suspicion of the sepsis the sepsis, sorry, of sepsis as well. But this particular example is from CCAM, and it is set up just for sepsis screening. Not necessarily maternal sepsis, all types of sepsis. So get yourself familiar with your trust's recognition of sepsis. Lastly, here is some information for you about maternal deaths. So the top graph here is for the entire world. The bottom graph is probably more appropriate to us in the developed world because we're less likely to suffer with like autoimmune diseases like HIV, and we've got more developed assessment tools, scanning, and appointments, etc. during the pregnancy. So it is going to be a little bit different. But if we have a look in the developed world, you can see here with the guide what people are dying from. So mostly are indirect causes. So that would be like medical causes. But you might want to look up some of these things here. So like, for example, let's look at my favorite, the pulmonary embolism. Pulmonary embolism is this color. So you're still getting quite a lot of deaths in relation to the other factors here. And then the same in the global. So it is interesting. If you want to look up further about maternal deaths, you can find a lot of information about that. I would recommend it. It is interesting. I know this doesn't show you an awful lot, but I'm limited in what information I can steal from the internet without copywriting. So look it up if you're interested in any further. And as I always say, this is an excellent dissertation topic, especially if you're not planning to get pregnant. All right, so let's round up. What we did for the assessment of the pregnant patient was, first of all, our usual approach, hands-off, end-of-bed assessment, Dr. ABCDE. We took a general history about the patient, you know, just their condition, what's led up to it, their family history, social history, etc. Checking the vital signs, checking if there's any pain. Then we'll do a full maternal history. So have a little look at the notes, read the notes, work out have there been any issues or problems during the pregnancy or with previous pregnancies. Have a look for red flags. Now there's loads of them. So you need to investigate every single one of these topics. So investigate miscarriage. Even if they say to you that there's no bleeding, you still ask any bleeding. Okay, right, was there any bleeding like in the first 20 weeks of your pregnancy? It's worth noting it down. Ectopic pregnancy, know the signs and symptoms, know how it presents, know what it is. Preeclampsia and eclampsia. Again, the signs and symptoms where the pain occurs, blood pressure problems, behavioral problems, headache, and then the eclampsia with seizures attached. Now, seizures can be tonic-clonic, they can be full-on seizures, they can be little absences, they can be as acute as that, just a hand twitching, that's still a seizure. So don't rule out seizures if they're like, no, it was just a little bit of a muscle movement, I must have a trapped nerve or something like that. Could still be a seizure, so that could still be eclampsia. Check the blood pressure. HELP syndrome, that again comes in with eclampsia. Any type of bleeding, whether it is in the miscarriage period, whether it's in the antepartum period, or whether it's in the postpartum period, think about why the patient is bleeding. Think about those placental issues. Always checking for PE, whether it's during the pregnancy or post-pregnancy, up to 3 months. Check on the patient's mental health, thinking to yourself about postnatal depression, thinking to yourself about safeguarding with the baby involved. And then double check for any signs of maternal sepsis. I know you would have already done that in the vital signs, but if this is your OSCE, you have to make a point of saying, right, now I'm going to recheck for anything to do with maternal sepsis. Okay, so hopefully that has been helpful for you. You will get a little bit more about pregnancy on Richard's course, and then you also get it in third year on Rob's course, and that's more about malpresentations. So normally everything goes fine. I want you to be, in terms of this module and how prepared you are, is I want you to be ready to jump on any red flags and not let people get injured or die unnecessarily. All right, fun way to end. Hopefully that's been enjoyable anyway. And I will see you soon for our case studies. Bye.